Now we have Dr. MARIAN PAULY. She is a senior oculoplastic surgeon from Giridhara Institute, Cochin. MARIAN will speak to us on differential techniques, refined results.
Good morning. I thank Dr. Thomas Jeresa for this opportunity. So I thought I'll just put a few cases across. So first is in the ptosis, what I did differently. So everybody is speaking about MICS, MIVS and MIGS. So for us, it is ptosis, that is minimal incision levator advancement, that is MILA. So this is a small video. Here the only difference is we are just making a small incision only. It's odious in
marking done. Traction sutures taken. An 8mm lid, crease incision done with the help of radiofrequency cautery. Orbicularis dissection is done. Suborbicularis dissection carried out in preseptal and pretarsal plane. Minimal pretarsal orbicularis is excised. Orbital septum is opened and retracted. LPS aponeurosis identified and sutured to the tarsus with non-absorbable single box suture with 6-0 proline after adjusting the lid height.
This is here we are taking only one suture. Usually in levator advancement we take 3 sutures and we form the lid crease. So now look at this patient. She is 84-year-old, underwent bilateral cataract surgery, and she had all the complaints: irritation, watering, she can't read. So she was actually in fact blaming our cataract surgeon for doing the surgery. So if you look at very carefully, you can there is a frontalis overaction, and look at her middle canthus. Upper punctum is in close opposition to the lower punctum, especially in the right eye. So she had punctal opposition syndrome, that is called functional NLDO, where actually there is no anatomical block, but she is symptomatic because of her opposition of the punctum. So she had ptosis both eyes. So if I operate only one eye, she will get a drooping in the left eye. Again, she will blame me. So I operated both eyes with the minimal incision levator advancement, and this is the postoperative result. And this is very fast, and you will finish both eyes in 15-20 minutes. And she became asymptomatic. So similarly, we can do this in very select number of cases where the lid is very thin and gives you a very good result. So now coming to facial palsy. So facial palsy, there are 2 types of procedures: static procedures and dynamic procedures. Static procedures, it helps in eyelid closure like tassorrhaphy, medial canthoplasty, lateral canthoplasty. You can load the lid with the gold, etc. But it will not give any dynamicity to the lid because orbicularis is still paralyzed. And so whereas in dynamic procedures, it helps in the eyelid blink as well as an improvement of lag of ophthalmos. So in 2019, I operated this patient with left facial palsy with levator recession and lower lid retract release. So after 5 years, again you can see the same, because I have not addressed her dynamic problems. So here what I did was I transferred the normal orbicularis from the normal side to the paralyzed side. That is called orbicularis oculi muscle transfer. It gives dynamicity to the lid. I'm just skipping the video. This is a very dynamic procedure. You can lift the orbicularis from the normal eye and transfer to the abnormal eye through a tunnel over the nose and suture it to the paralyzed orbicularis. So now I have done orbicularis oculi muscle transfer for her, and this is a postoperative result with improvement in lag of ophthalmos, and she is asymptomatic in terms of watering because orbicularis pump has come back. So this we are, so what I have done differently is nowadays I'm combining both static and dynamic procedures. So this is post-schwannoma excision, right facial palsy. I did raw lift retractor release, lateral canthoplasty. He had ectropion. I did a small skin graft also to increase the anterior lamella combined with orbicularis oculi muscle transfer, and he did well at 1 year follow. Even the blink also has been improved. So even we have documented this with blink rate analysis using LipiView. The blink has improved. The third thing is like facial specific implants in orbital reconstruction. So the routine thing is to put the plate and screws and correct the original bone defect. So now with the 3D printing technology, we can get patient specific implants. So he is, you can see a depressed fracture involving the frontal bone, and eye is phthisis with the third nerve palsy, total ptosis. So with this 3D model, you can see this depression is created, and we made an implant, and it has been incorporated to the patient. So it gives more accuracy to your reconstruction and gives very good cosmetic results also. Thank you.
Because I have no idea.
Thank you, Marian. How do you titrate how much of the transfer you have to do in this lag of thalamus?
That is actually blind because the aim is to transfer the normal orbicularis to the paralyzed orbicularis. The assumption is new motor neurons are coming up. So we are just awaiting the neuromuscular studies to see the nerve conduction. Anyway, blink is coming. So blink can come either mechanical effect also, because when the right orbicularis is functioning, the same orbicularis is functioning in the left also. So there is a blind procedure. There is no titration. Only thing, don't take too much of orbicularis from the other side. Little bit of pretarsal and more of preseptal orbicularis, because pretarsal orbicularis, especially muscle of Riolan, helps in more blink. So.
And is there an option for a resurgery if it's inadequate?
I have got only 1.5 years follow-up now, the first patient. So that I have to see after 10 years.
That's quite interesting actually. It's nice to see that it's working.
Yeah, it's now even patients are very happy because orbicularis pump started functioning, so there is no watering. Most of the patients are not really bothered about the lag of thalamus, but they are worried about the surface problems like irritation, watering, etc. Yeah. That is improving.
Yeah, so. Especially that 84 has become 48. Yeah. Thank you, madam.
Thank you.
Thank you.